having me. I am now going to try and share my learning and a little bit of experience about the fractures of the humerus and non-unions. I understand that you have covered the two ends, and today we are going to try and concentrate on humeral shaft.
Sorry, Mr. Khaleel, we can see the presenter view. It's not full screen for us.
Oh,
would you please making full screen, sir?
Yes, sir. I thought it was full screen. Let me see what I have done wrong. Can I just
Start again.
I'm so sorry.
No problem at all, sir. Yes, full screen, sir.
Is that full screen yet?
No,
not yet.
No. Okay.
Not yet.
Give me a second. I thought I had full screen.
Just on the icon lower down.
Yeah, that's it.
Yeah, that's okay.
Perfect for us. Yeah.
Perfect. Okay, sir. So today we're going to concentrate on the shaft and how to best manage it. Essentially, we can treat the shaft problems non-operatively or operatively. And one of the things that when you have to do a talk is you have to go and do to read about it. And here's a paper that's just been published. It's from Scotland, and it's a systematic review of the treatment of humeral shaft fractures. And essentially, all we do is manage the risk differently. So if you treat them non-operatively, you get one set of risks, and if you treat them operatively, you get a different set of risks. And in the end, that's all we're doing. We're trying to manage risk. So their summary, and like many other systematic reviews, essentially humeral shaft fractures are best managed non-operatively. And if one gets into a problem subsequently, it can be treated pretty easily. And therefore, that would be the end of my talk. But then you would be bored for the next 20 minutes, so I'll try and keep you entertained. When do we not have a choice? So when must we always think about operative treatment? Well, there are a few conditions, such as when one has an open fracture, or when a patient has involved in polytrauma. And I have said almost always when there is cancer, because these patients are coming to end of life and we want to make their life comfortable. The other circumstances are all relative indications. So we're treating pain when we can't manage this non-operatively and the patient continues to experience pain, or when there is going to be a prolonged period of loss of function in a manual worker, for example. And then in these two circumstances, one may think of intervening surgically. When we look at our implant inventory, either ends of the humerus have fantastic anatomical shaped, lovely pieces of shining metal. The workhorse of the shaft is still a compression plate. The nails keep coming into fashion and going away and then keep coming back. We're now, I think, on the third generation of nails. And the monolateral fixator is essentially a temporizing implant in our experience. Diaphyseal fractures, as everybody has experience of, is bimodal. The young chaps come off their motorcycles while the elderly have simple falls but end up with quite nasty looking fractures. And as we said, the non-operative treatment is essentially functional bracing. A reasonable amount of deformity is acceptable, but the function is pretty good. The non-union rate depends on whether one is a proponent of functional bracing or one doesn't like functional bracing. But there is a rate of non-union with this method of treatment. But by far the humeral fractures treated with plate and screws. One can use the easier method of the anterolateral approach. This does, however, produce an unsightly scar. And it's best done for the proximal and middle shaft. And in my hospital, we use an image intensifier, which shows us this brilliant, all the nerves in the right places. I wish. we still have to to find these hidden things using landmarks and measurements. I have borrowed the best manual available for the anterolateral approach through the deltopectoral groove, and basically splitting the brachialis between its internervous planes. And one can then extend the incision proximally, but there is the problem comes when you wish to go down lower. So ideally, this is suitable for the proximal and middle third fractures. One must always try and remind young chaps that the lateral retractor is going to damage the nerve, so be careful. My favorite method is the posterior approach because we tend to deal mostly with the middle and distal third fractures. It is fiddly because you have to get the position of the patient right, and then you have to identify the nerves. My anesthetist is now able to help me use the ultrasound, the Doppler, to tell us where the nerves are, because remember, in the cadaveric section, it's very easy to find, but when the humerus is swollen and bruised, it is, and the arm is wobbling about, it can be a challenge. So we mark out our nerves and we just remind ourselves that there are other helpful methods, such as the 2-finger breath at 2 centimeters above the aponeurosis. But remember, these look fantastic in the cadaveric sections. And you can identify the nerve and protect it, because that is the real challenge in these fractures. So as we said, our workhorse is the compression plate in the compression mode, and the 4.5, either the broad or the narrow, works very well with either 6 cortices or 8 cortices on either side. If one has a comminuted fracture, one can consider a bridging mode with the near and far technique. And if you're really clever, which I'm not, I have no experience, one can consider using the minimally invasive approach, which requires identifying the nerve and maybe using anatomical plates to achieve fixation. In our practice, the nail is now used in pathological fractures. So this was done in my unit, I think last week or the week before last. But we have used nails for shaft fractures in the past. And just to touch on patients who have accompanying radial nerve injury, these can still be treated with non-operative measures. So this is not an absolute indication for surgical treatment unless one has done manipulated the fracture, such as the Holstein-Lewis post manipulation. Now, let us, hopefully that covers the management of shaft. We'll look at my learning of the non-union of humerus. So essentially, it comes in 2 forms. We have the failed non-operative treatment, which, as we've seen, varies from 2 to 10%, depending on what series you look at, or when the patient has had fixation, and unfortunately, it hasn't gone according to plan. So when one is dealing with this, I'll think about looking for a cause, and I grade them into 2 forms. Causes that are unfortunately not in the surgeon's control, such as the weird anatomy or the blood supply of the humerus. In terms of the shaft fractures, the non-union tend to be more predominantly in the proximal third or the distal third, and these are usually due to changes in the shape of the bone, the muscle forces, the fact that our humeral braces tend to end right at the fracture site, and occasionally other features of anatomy can interfere. What is also not in the surgeon's control is what the patient gets up to, and clearly the energy of valence has a direct consequence on the soft tissue and the ability of the bone to heal. And finally, what the lifestyle of the patient, the age of the patient, and what they get up to has direct consequence healing of the bone. And sometimes, even when we've done everything right, it's just pure bad luck. We cannot find a cause for a non-union. There are some factors that are in the surgeon's control. And of these, the best is the patient selection. I know which of those humerus I would like to manage and which I would like to send to my colleague Muhammad Imam. And we have to reflect on our technique. Did we time this intervention correctly? Did we optimize our approach? And did we make the right choice of the implant and execute our surgical plan? So when I was training, my boss taught me, or my first experience with humeral non-union was of the distal humerus, which is quite a debilitating condition because the hand is perfectly functional, but the patient can't actually position it. And as we know, what makes us humans is the thumb. So if the patient can't use their thumb optimally, we're not quite humans. And my boss used this implant, which is the Coventry infant hip screw. It was stainless steel. It was essentially a locking type device. And what we would do is we would put the implant through an open approach laterally, and we would get fantastic fixation. Unfortunately, this implant doesn't exist anymore. The company has withdrawn it. And I had to do one recently, and I had to order one from a Turkish company that had to make it for me. But the point of this will become clear in a second. So let me share my decision-making process when I come to humeral non-unions that I have learned, and I still continue to learn. The first question I ask myself is, do I need to alter the anatomy? Do we have to restore anatomy? And sometimes we can get away without having to significantly restore anatomy. The second question that I have to ask is, especially with the shaft, what are the state of the joints above and below? If one is trying to treat a humeral non-union with stiff joints, one can have a problem. Now, sometimes supple joints can be really supple and excessively supple. So you can imagine when trying to treat this type of problem, if the joint has been stiff for many years, there is in fact impossible to get any method of surgical fixation if the joint is that stiff. So in surgical planning, one has to then address the joint and then think about how to fix. And then when biology has simply failed us. So I call this process bleaching of coral or coralization of bone. So essentially, the end of bone has become fossilized or coralized. There is no blood supply. Now, the only method is then excision. We cannot convert dead bone, into living bone by any simple surgical method. And then the enemy of everything are the bugs, as we've seen. So this is my simple ABC decision-making process in treating humeral non-unions. Probably the most important thing that has been helpful in our decision, or my decision-making, is the advent of the SPECT CT, because this can tell me how much of the bone do I need to sacrifice. Because in the past we had to rely on the paprika sign, which was intraoperative. But here now we can actually have some idea preoperatively, and that we can adjust our surgical plan. So once we've had this, I now think of low risk surgery, because the person who is going to take all the risk is the patient. And therefore, I want the smallest surgical footprint on the patient's behalf. So let me share our experience. This was when my last fellow reviewed our results, and we insisted on we must have at least 2-year follow-up. So this was when they looked at 2018. I think I may have done two more since then. So you can see that we're treating about 2 shaft non-unions a year. So it's not a big burden. And I'll tell you why that has changed. Majority of our were diaphysials, and majority were actually plated. But our biggest generators were the nails. But nails have gone out of fashion, and so I suspect we're doing fewer shaft humeral non-unions. And this is what I'm talking about, surgical footprint. Of the 24, we actually only opened 4 fracture sites. Okay. Our mean time in the frame is about 3 months, and we've developed a very simple, cheap method of scoring our trauma patients with the cost score. And as you can see, we're pleased with so far, thank God, with the results. So here is a patient that we had no choice. In order to restore this patient's mechanical axis, the metalwork is interfering, so we have no choice but to open. But you can then imagine that the palaver that I put the patient through, the risk of looking at their radial nerve again. And as some of us who have had that bitter experience where we have looked and protected the nerve, but the patient still wakes up with a wrist drop, that's quite a significant risk that the patient has to go through, because we are hopeful the wrist drop will recover, but until then the hand is not functional, and the patient keeps looking at us. Here's another one that we had to do, which is a builder. He couldn't tell me how many operations he had on his distal humerus from a high energy fracture, but he started developing radial nerve palsy, and which is why we had to intervene. So now you can imagine here's a patient who's already having ulnar nerves, nerve symptoms, and we're going to go and explore his nerves even more. So we managed to get him sorted out, and thankfully his ulnar nerve symptoms improved. So unfortunately, I've not been able to get every one of them to unite. 21, we're lucky. 2 had fibrous union, so they were asymptomatic. 1 we intervened and had to replate. So we're lucky in that we had a whole bunch of inside infections. We don't keep count of those. We did not have any deep infection. And 1, we had to go back and remove the plate that I had successfully ignored the first time round. Our learning, or my learning, has come from my learning of treating acute fractures. So here is a young lady who came off her bike, and after her treatment, that's the result we were able to achieve. And here is quite a nasty pilofracture, and we were able to achieve that result. So when we looked at this, we came up with why that should happen. And what my learning has been that if we can restore the mechanical axis of the bone heals with primary healing. And we shared our learning. And I was looking for biological evidence, or at least evidence for this. And I found this fantastic piece of work done by the vets. So these are veterinary surgeons who have treated dog bone with gap, dog femur, with locking plates. And in 1 set, they have put all the screws, so near, far technique. And in 1, they've gone for the near, far technique, but in the diaphysis. Okay. And what they noticed was that during physiological loading in the diaphysis, it didn't seem to matter whether you'd done near far or completely locked. But if one should just change the mechanical axis slightly and make this a more cantilever fixation, they both fail spectacularly within physiological load. So that is what we're talking about. That if one restores the mechanical axis, the method of fixation is probably irrelevant, because bone doesn't care. It just wants to heal. So let me share three cases. I hope I'm not boring you. So the first is this young doctor. So she's a colleague who unfortunately had a low energy sport, or moderate energy sports. I think it was one of these rollerblading accidents. This is her 2nd internal fixation for a proximal humeral fracture. So by the time, and unfortunately that didn't go according to plan as well. And so she's now 2 years since her original injury with 2 operations. So we have to come up with a surgical plan. So the surgical plan with the low footprint would be to dynamize the fracture site, and we would want to compress along the mechanical axis. That would be my plan. And if we could achieve this close, that would be ideal, so that we do not put her through any other risk. So we we draw the mechanical axis, and we get distal fixation with a simple wire and a half ring construct. And then we achieve proximal fixation with 2 half rings and a wire. And look, once we compress along the mechanical axis, look at what happens. You know, that cartilage that she has in the gap is nicely compressed. Now, in our unit, in order to improve my learning, all our patients have CT scans after any form of fixation, and we can look at how we're compressing her along the mechanical axis. And this is 3 months. Now, we did an EUA for her when we take a frame off, only because she's a colleague and I wanted to be absolutely sure. And secondly, we wanted to be sure that we were not producing impingement from her metalwork, because then I would look very foolish in leaving her metalwork behind. But clearly, as you can see, there was no impingement. But all we did was to dynamize the fracture side by taking the screws out from one set. And this is her 1 year after plate removal. This is my second case. This is a poor 85-year-old lady who had a closed fracture on her dominant side. She was independent. Now, you can criticize her fixation. I don't. This is what the surgeon came up with a plan. But unfortunately, by the time she came to us, what you see here is the suction dressing, which tells you that things are not so good. And this is within 2 months. So clearly she's got infection. So let's come up with a plan. We need to do open excision. So once we excised all the necrotic tissue, we are left with bone, and we can actually do bone shortening, because the upper limb can tolerate a reasonable amount of bone shortening. And if we compress her along the mechanical axis, at least we will hold the bone in ideal position. And then we kill the bugs with killibugs. So that is it. This is after excision. I didn't know where those screws were, and if they were not interfering, I left them alone. I was able to get a position that was a monofocal compression, and then we applied a very simple frame. And this is the CT scan showing the fracture site between the 2 rings. And this is her 1 year later. Thankfully, we managed to get rid of the infection, and she had functional use of her hand. So now let's look at this colleague's secretary, who's had a cemented hemi for a fracture, I think. And then, unfortunately, following another fall, we now have a periprosthetic fracture, and this was internally fixed. And then we have the oops position. So now what do we have? We have no infection. We have supple joints. Her hemi is still working, and she has a good elbow function. The implant is also well fixed. So our surgical plan here with low footprint would be to keep the implant, probably shorten the humerus, and apply compression along mechanical axis, which is what we did. And by the grace of God, we achieved a good result on this occasion. Thank you.
Thank you so much, Mr. Khaleel, for this very interesting talk about humeral shaft fractures and humeral non-union. Thank you so much, sir. We are ready to receive questions.
Yes.
I got a question. You got many wonderful ideas in your presentation, Mr. Khaleel. Really, I really like it all. Let's start with the distal humerus non-union with stiff elbow joint, because this is a very critical thing. And I saw patients keep failing because all the fulcrum will be at the fracture site, so it won't unite.
Yes.
So as a practical answer, how would you approach this? Do you do something for the joint first before fixing the non-union site?
So the case I showed you, the young builder, that was my longest operation. I started that case at 9 o'clock in the morning, and we finished at 5 in the afternoon, because we spent probably all of the morning and the best part of the afternoon trying to free his elbow, the arthrolysis, gradually and slowly. The point is, we can use the frame and do it gradually, but we lose control when we use the frame, and if you're not careful, we can actually dislocate and sublux the joint, which doesn't help. So I have tried that with hinges, and on one occasion it worked very well. On another occasion I had to go back and we had to sit down and do open surgery. So the short answer is there is no point fixing a periarticular fracture if the joint is stiff. So let us look at what our options are. Some of my fantastic young colleagues can offer arthroplasty surgery if the patient is of appropriate age, and that would be a better option for the patient. One of the other options is to accept the pseudo joint. So if the patient is comfortable and the thumb and hand is functional, accept the pseudoarthrosis, because we are not, if all our interventions are going to make the patient's life miserable. So if you're going to go down the route of surgery, we need to do things. Some method of arthrolysis, arthroscopic assisted, open, but not losing the joint. So what we want is a functional arc of movement. What we achieved in that chap was probably just another 20 degrees of movement, and then a method of fixation that will survive a stiff elbow. Okay, so what we found was that the plate, the pediatric plate, is 4.5 to 5 centimeters width. Okay, and we are putting that plate, we're using the plate in its best position, i.e., instead of asking it to work in this way, we are asking it to resist in its width. And it is stainless steel, it is not titanium. And we used a 6mm screw in the diaphysis. I have had to, as I said, I've done one recently where I had to order that kit from Turkey, because that company doesn't make that. There's no infant DHS. Unfortunately, they gave me titanium because that's what they could do. I still think that stainless steel was a better construct. So I hope I've answered your question. I've tried to answer the question.
Yeah. Just so you're losing the joint, fix the union, and then post-operatively rehab. Do you protect the range of motion?
No. The bone loves load.
Okay.
So in fact, what I didn't put in this slide, which we are trying now, is 4 patients who have this are in this state of delayed union. So the fixation is still intact, but there is no activity. So what we now do is tell them to go and do bench press. Okay, so we are harnessing the loading capacity of their muscle, because what we have to do is reassure the patient that if it falls apart, if the metalwork fails, we can fix them. Because usually the treating surgeon says, oh, please don't load the humerus. And what we are saying is directly opposite. Please go and do more. And so far I have 4. We're keeping the data. Eventually, hopefully, when I have 10, we will be able to write that up. And it works both in the upper limb and the lower limb. So I think asking a patient not to use their arm is actually counterproductive to everything. The joint goes stiff, the bone is not loaded. So sorry. So whatever fixation you have, please load it.
Yeah, that's perfect. Thanks so much. Just another question from myself also. It's a very good idea compressing along the mechanical axis, and I really I read that paper about describing this. Just one thing about the healing without callus. We used to read and to know from the literature that callus, it's there or not, it's about the strain environment of the fracture site, about
Yes.
the stiffness of the construct. And
Yes.
it's really a new concept, the compression along the, you didn't mention the stiffness of the construct, or does it interfere with producing the cast or not? So just, I want to know your thoughts about this.
Okay, so so if you have any experience of distraction osteogenesis,
Yeah,
or
yeah,
bone lengthening, what happens? You pull the bone. Do you see callus? No,
no,
we don't see callus. Why
yeah,
not? We have gap, we have bone growing.
yeah,
So what Professor Elizarov was able to do, and he was able to grow bone at 90 degrees to the mechanical axis, because control. So this is what I think happens. Our bone has only read O-level physics. Our osteocytes only respond to strain, and they respond to strain in the direction of the mechanical axis by producing bone.
yeah.
So callus is actually a failure of that process. So when we see callus, bone has to do something else. It has to produce cartilage. Whereas if we now allow force along the mechanical axis, bone cells will produce bone cells, just like distraction histogenesis.
That's perfect. That's good answer. Thanks so much. Thank you. Get questions from colleagues. What about bone grafting? Why not use it in all cases as an enhancer of union?
Okay, so I thank you. I get asked this. My answers are very simple. They're well rehearsed. So when we take bone from anywhere, it is dead bone. Yes. So now
Exactly.
tell me, when you do fracture surgery, we talk about debridement, which is to remove dead tissue. So I have a fundamental problem of putting dead things into fracture sites. Okay, so that's one question. The second is, what is cancellous bone? So this is all my residents get asked this question. Have you seen cancellous bone? What is the blood supply to cancellous bone? Cancellous bone is 1 cell thick. And it is just 1 cell thick. It has no blood supply. Okay. Now all of us are sitting in a room. Yes. Your room, if you just look around, this is what bone is. It is walls, it is articular surface on both ends, and in the middle is emptiness, is cancellous bone. So a bone requires the walls, the cortices, to keep it intact. In a fracture situation, it is a failure of the cortices, not the cancellous bone. In periarticular fracture, it is the walls that have failed, which has allowed the struts, the subchondral bone, to collapse. We need to restore the subchondral bone by supporting it with the walls, not by putting dead nothing underneath. So sorry, that's my long-winded answer. My short answer is no, I don't use bone graft.
Okay. Even in the situation that you feel that the failure is biological because the lack of the osteoinductive power, so you use it as osteoinductive?
So what Professor Elizarov showed was that if you do any bone osteotomy, if you do corticotomy, and you leave the periosteum intact, you increase the limb blood flow by 800% for the first few hours, and which goes to up to 200% for 2 weeks. So just opening the fracture site and opening the canal, but we have to make sure that that bone is not what I call coralized bone. It's not dead bone. So you have to have what the Russians call vital bone or living bone. So if you have vital bone and you have prepared that is a bigger stimulus to bone than anything else I can think of.
Yeah.
Sir,
Thanks
what
so much.
about the vascularized bone graft, sir? You still don't prefer it?
I don't use it because I cannot see the point. I mean, I truly do. It has no mechanical strength. It is of no strength. So the only reason why one would use it is to kill dead space. So dead space management is different. Because what happens, and we use, so even in our plateau fractures, when we have elevated, what we have done now is we have created a dead space, which will be filled with blood. And our wires or our implants are going through that. And if we are not careful, that's going to end in tears. So in order to manage dead space in bone, you can fill it with chalk, with anything. Cancellous bone that you have put in only lasts there for about 3 to 6 weeks. It's not there any longer.
Vanish. Another question from a colleague: how much shortening is accepted in the humerus?
Okay, so so in the lower limb, it's easy. We try not to shorten beyond 3 to 4 centimeters because you get the hamburger effect. In the upper limb, because the muscles are not that big, you can shorten reasonably. And one of the things that we can't do in the upper limb that we can do in the lower limb is a transverse incision. So now if I'm doing acute bone shortening in the lower limb, I use instead of a longitudinal incision, I use a transverse incision. And it's amazing how you avoid that hamburger effect. In the upper limb, I've shortened up to 4 centimeters. I've not had the need to shorten more than that. Bone transport. So if you're worried that what you could do is you shorten, and if you think that you're going to have a problem, you can always come back and do lengthening. I've never had to do that.
Yeah. Last question from our colleague. Did you try bone stimulator in such cases?
Yeah, so you can imagine we have patients who have had 4 or 5 operations. We have tried everything. We have tried. I tried BMPs. I tried, and there is no substitute to mechanical access restoration and physiological. So vital bone. It should be bleeding bone, healthy bone, mechanical access restoration, and physiological load. I think that it's as simple as that.
Yeah. We're done with the questions, but just to highlight 2 things for our junior colleagues about 2 common questions. Radial nerve palsy, it's not an absolute indication for ORIF, isn't it?
Yes, sir.
Just to make this clear.
Yes.
So you can proceed to your
so,
plan and then.
Yeah. Sorry. Yeah. So the typical fracture in a closed injury, open injury is completely different. Okay, so in exactly. A closed fracture, yeah. It's usually a lesion in continuity. So the nerve is intact. It's a physiological block. And the problem is, do not do EMGs early. You have to wait for about 2 to 3 weeks. The problem is that a patient having a wrist drop is the worst thing in life because neither the surgeon nor the patient sleeps happy.
And the last bit is the Lewis fracture, the commonly named distal third fracture. It's used to be go to surgery. It's unstable fracture, distal. It's a common sense about in our junior colleagues. So I just want to highlight your opinion in this.
So there is there are 2 things. What Holstein Lewis described, we just need to be careful, is a low energy spiral fracture. So what people did was they manipulated it. Okay. Now, if you have a patient with a low energy fracture and they have a radial nerve palsy, the nerve is not damaged. The nerve only gets damaged when you do the MUA. So if we have done an MUA and then the patient has a radial nerve palsy, we are duty bound to go and untrap the nerve.
Yeah. Okay. Thanks so much, Mr. Khaleel. It's I got here very wonderful ideas. Thank you so much for this nice talk and discussion.
Alhamdulillah. Thank you very much.
Thank you so much, Mr. Arshad Khaleel, for sharing your experience with us tonight. And we hope to see you again, sir.
Inshallah.
Thank you so much.